Good afternoon, Dr. Gebien, and thank you once again for agreeing to sit down with us today in order to talk about your advocacy work in the area of solving the current devastating opioid crisis.
Okay.
Perhaps we could start off by asking you to shed some light on the escalating overdose death statistics that are impacting both Canada and the United States.
In Canada last year, the numbers have increased from January to September of 2017. There were more deaths in that time than there was in the entire year before that in Canada. So it's going to reach approximately 4,000 people this year. And that's about a 45% increase from the previous year. The same thing's happening in the United States. More and more people are dying from unintentional overdoses. And so it's very worrisome what's going on. Despite efforts that are being made, I think nothing is actually making any real changes in the statistics.
Are you surprised?
No, because so far the only real management that's been invoked is to bring out the naloxone, the antidote to the opioid overdoses. And so that's just a temporizing technique. This helps people it buys people time. But it's not actually affecting their mortality, not improving mortality over time. We need to treat addiction, that's the illness, and mental illness as well, rather than just overdose itself and prevention of overdose.
By way of clarification, what is the population that is most impacted by the opioid addiction death cycle?
The average users are male between the ages of 25 and 44. The ones that are most often overdosing would fall in the same cohort. But this is people from all walks of life. We see in the mainstream media that, on television, that affects homeless people, marginalized people in the downtown inner city cores. But really, the actual opioid crisis is affecting people from all walks of life. It's just not so obvious. These are people I would have met in rehab when I was there. People who are construction workers, manual laborers, doctor like myself who went through it, dentists, lawyers, you name it, people from all walks of life, from all backgrounds, geographically as well. It has spread right across from west to east in Canada, mainly started in, in British Columbia. Now it's affecting Alberta, which is just to the east, and now it's it's already stretched well into Ontario, and now into the maritime provinces. In the United States, it's everywhere. Small communities, small farming communities. This is really the true epidemic, and as well it affects people in the inner cities across the United States as well.
So you've talked about a broad spectrum of individuals that are impacted.
Right.
Is there a commonality, a common thread between all of them that gets them into the problematic, I think you've referred to it as opioid dependency?
That's more complicated because there's people coming from different situations. There's people who are chronic pain patients who inadvertently become dependent on the opioids. It can affect younger people who are recreational drug users, perhaps being a little too reckless and accidentally getting themselves hooked on it because it's so powerful. The opioids in general, but particularly fentanyl. And then there's people like me who were using sort of middle age, and started off with back pain, but I had other issues going on in my life. Like my life situation at that time was not going well, and mental health issues. My mental health was poor at that time.
Let's get one question out of the way, and I know you may be uncomfortable with it, but you've admitted that you were in the past a substance abuser and admittedly made some bad decisions in your past. Why should we trust you now in terms of your opinion?
Well, first of all, I have over 3.5 years now of long-term sobriety. But over this time, I've learned to trust myself and to get back to who I once was. In fact, I'm stronger than I once was. But I'm now in the situation where I'm making proper, healthy decisions. And I trust myself now. I know I'm do my best as far as making my decisions. And I'm no longer ill, I'm no longer sick, I'm no longer using. And so to summarize that one, it's just I'm in a situation now where I can trust myself and I think I'm doing the right thing.
Can you explain why addiction is not a moral failure, as many people suggest? Some people ask, why don't opioid abusers simply make other good choices and stop indulging themselves? Isn't the decision to use or to continue to use a personal choice? Why shouldn't we simply hold drug abusers to a high standard of personal accountability?
I think it's a myopic, closed-minded approach. I can understand, though, people on the outside who don't understand addiction to look and say, well, what's wrong with these people? Why aren't they making decisions? They know what they're doing is wrong for them. We're talking about people's mental health here. And people, when they're in the throes, the depths of addiction, their judgment becomes impaired. And it's not a moral failing, it's that they are sick people. We need to look at things from a different approach. By applying my own morals on somebody else is not fair. From a healthcare perspective, they have a right. As treating people with addiction as having a disease or a medical illness, it's time to look at them as people who their ability to make judgments is impacted.
So, addiction is a disease, is what you're saying?
Yes, personally, I look at it as a mental illness, a form of mental illness, as opposed to the word disease. We don't consider anxiety, depression, OCD, post-traumatic stress disorder, rather than diseases. So I personally coin it as a illness rather than a disease, but for all intents and purposes, yes, a disease would do fine as well as how it's classified.
Now, you've come here and you've earlier indicated that you've developed what you consider to be a workable model in terms of a solution to the opioid crisis. Can you just briefly explain, I know you're going to get into more detail, discuss what makes your model different from what is currently going on?
Unfortunately, what's going on right now is there's a lot of time and money put into treating the for overdose prevention, which is the antidote, giving naloxone. Which is an excellent way to prevent, to help stem the tide of opioid overdose, but it's treating the symptom and not the cause. What I'm proposing is to treat the cause, and this is what is it that seeds an addiction in the first place? Are there mental health issues? Is there mental wellness issues, meaning that it may not be a disease or an illness going on, but just a poor situation that somebody's in? There's many ways to approach this, but looking at the deeper rooted causes of it is important to solving the crisis. That's the biggest difference between what I'm proposing and what's already available. We could throw all the money in the world towards overdose prevention, but that's just a temporary measure. Same thing goes with opioid replacement therapy, with methadone or Suboxone. The more and more pressures, and they can be very helpful in this situation, but that's not treating the actual problem in the first place. So my proposal, treat the problem in the first place.
And as an overall description of the model which you're proposing, what is the essence of it which encapsulates that whole concept of treating the underlying issues?
It needs to be seamless. There needs to be, first of all, there needs to be a easier portal of entry for people to get help. I mean, sometimes people are at rock bottom and they're in jail or at the hospital and they get help, but there needs to be an easier, more fluid portal of entry for people to ask for help and get help in a timely manner. The next thing is to have seamless transition from whether it's in the emergency room to a detox to rehab to aftercare and then long-term care in the community. But it needs to be seamless, and this doesn't exist. It's very much of a patchwork, ineffective treatment model that's pretty much in place now. And what also fragments it or fractures it is that whether a person has money or not. I mean, if they have medical insurance, that's great, they're covered, but what happens if they don't have medical insurance? How does the state pay for this person? And what's happening is it's a barrier to access. Finances are a barrier to access to medical treatment.
What do you mean by a health continuum?
So this is where a person's plugged into the healthcare system, as opposed to the worst case scenario, somebody, let's just say they go into detox, but there's no rehab bed available, or there's no positions at a daytime treatment rehab. They're left to their own devices, and this is a high risk period for them. They're sick, especially with opioid withdrawal. They're very sick at this point, physically sick, and they're very much at high risk for relapse. And unfortunately, in recovery, if they've had some clean time under their belt, they could start to resume their previous dosing and inadvertently overdose and die. So that's what we don't want. So that's why we mean by the proper way to treat the word for it is seamless, meaning that they're transitioning from one area of treatment, like it's detox, to rehab bed or outpatient rehab, in real time from one day to the next. There's no gap there where they're left to their own devices.
The big problem is relapse. Mm-hmm. How significant is this concern with relapse? How often does relapse occur?
It's extremely common. I can speak even from my own personal experience. It took a few goes to get it right. I had a few relapses. Fortunately, I survived it. I mean, one of them I almost died. So it's not relapse. Some people say it's a part of recovery. I wouldn't say it is universally for everybody, but it was for my situation and for most users. The goal is to invoke harm reduction in the situation, to minimize any harm that they're doing for themselves. And this is where it goes back to this continuum that if they're plugged into their medical system, if they have quick access to doctors, if they need to see their physician or a nurse or a drug treatment counselor, that they'll have it available right away. I mean, life is full of stress and unpredictability, and we need to ensure that people, when they're so vulnerable, like they are in the early stages of opioid withdrawal recovery, that they have access to the proper healthcare professionals. This is what leads to recovery. This is what helped me get healthy and start making some good decisions. And so I needed to be immersed in this. I need to be part of a community as well.
This seamless health continuum which you describe, it sounds very simple, and if I'm understanding it correctly, it's like almost a team approach, and
right.
One person does, or one entity does what they're supposed to do, and there's a handoff, like a baton being handed off to the next. Mm-hmm. And as long as you keep going along the line, you don't have an opportunity for the baton to fall, then everything should be good.
Yeah, good analogy.
So let me just ask you a question. If this type of health continuum model works, why isn't it currently being used?
I mean, don't ask me, because this is what needs to happen. This is the problem. So this is where the solution lies, and this is exactly what I was trying to suggest out there for other people who are policymakers. This is where the next step needs to be taken. We need to let go of our judgment and stop judging, putting our moral standards on people who are sick, who are in the depths of their addictions, and giving them a chance for recovery. Which doesn't exist right now. I mean, the main effort is giving naloxone, but having, a continuum of healthcare professionals and seamless transition from one stage of recovery to the next. That is where the solution lies. That's exactly what I'm trying to say. That needs to happen for us to have any sort of inroads on the opioid crisis itself.
Why don't we have enough detox facilities available?
It comes down to money. I think the policymakers are not really. It seems like I've spoken with them in Canada, but it seems like they're interested, but they're not doing anything. Some throwing money at it as well. I mean, it needs to be an organized thing. So when I'm saying money, it needs to be organized into evidence-based solutions. So it seems like they're disinterested. They're not willing to like, for example, in Ontario and in the United States, we're not considering it to be a true emergency. A public health emergency is one thing, but that's not the real thing. We're talking about a true state emergency or provincial emergency. This is where the government can start putting in proper programming and money to help organize an orchestrated response to it. So the problem is with the policymakers. It seems like a lot of talk is being made, but no actual solutions, no actual work is being done to try to look at it from a multidisciplinary team approach and providing universal care to people from all walks of life. It's really simple, but it's not being done.
Why are they not gravitating towards it?
I think that people are still stuck in the stigma of it. I think there are people in these positions, higher positions here, and who the policy can be coming from, that they are stuck, unfortunately, in applying their own standards to other people. I think it's being because of very judgmental people who aren't really taking this from a sympathetic standpoint. I think that they are applying their morals upon others who are ill, and it's affecting their policy making in the first place.